biomarker of the cardiac disease. Okay, coming to I will go more to my presentation. Coming to the my overall presentation is on introduction to biomarkers and its their importance, overview of the cardiac diseases and important cardiac biomarkers and their utility, novel biomarkers, and the conclusion. Okay. So if you have any doubts, please ask it then. So first of all, what are biomarkers? Though everyone are listening to this new terminology nowadays, I want to say that this biomarker definition exactly. Some people are just drawing the blood and the patient is getting admitted. Some patients, the doctor drawing the blood and sending it for investigation. Some people are saying it's a serological investigation. Some people are saying it's biomarkers. What exactly? Why is the so into the biomarkers definitions, characteristic that is objectively measured and evaluated as an indicator of biological process, pathogenic process, or pharmacological responses to a therapeutic intervention. This is the definition what I could say. So what does this biomarker say? Yeah. What does this biomarker say? It gives a normal biological responses, pathogenic processes, and also pharmacological responses to a therapeutic intervention. So in the side, you can see, so it may be blood or tissue or specimen, it may be molecular analysis, data analysis, biomarker identifications. Okay, types of biomarkers. Coming to types of biomarkers, we are having many things. Like we can call it as molecular biomarker, radiographic biomarker, histologic biomarker, physiologic biomarker. So directly I can go to cardiology biomarkers, but still I want to give this a small introduction. So molecular biomarkers means it may be your plasma glucose, serum glucose, fasting blood sugar, like that. Radiographic X-rays means obtained from imaging studies, not X-rays, like bone mineral density, like that. Histological biomarkers like staging of cancers. You are going to take out the specimen, sending it for biopsy. So it ultimately it helps in the staging of the cancers. So it is a histologic biomarker. Coming to physiologic biomarker, it measures the body routine activities like blood pressure, etc. So biomarker means which indicate the functioning or deranged function of that particular organ. So there are many biomarkers, like it may be diagnostic, monitoring biomarkers, it may be pharmacodynamic biomarkers, predictive biomarkers, prognostic biomarkers, surrogates, or safety biomarkers. Diagnostic biomarkers means in general, just it is means yes, if this is there, yes, troponin is elevated, yes, there is myocardial infarction, like that. Monitoring, just to know whether the patient is in the stable condition or not, as long as he is under the treatment. Next, pharmacodynamic. Yes, pharmacodynamic is how the treatment is going on. Predictive. The predictive biomarker is something different. Whether this medicine will work or not, ultimately you are predicting by the biomarker levels. So you are assessing the fasting glucose, then you are going to give insulin. Then ultimately, when the insulin is not sufficient, you are going to say better change the insulin. That is predictive biomarker. Prognostic, whether the patient is landing into trouble, complications or not. How is the prognosis? Of course, all biomarkers are basing on prognostic only, but diagnostic and prognostic, there is slight different. Diagnostic at present condition, prognostic how in future, how he is going to land. That is a prognostic biomarker. Surrogate or substitute. Yes, substitute means surrogate biomarker means yes, LDL, in case of LDL or HDL, there is no particular biomarker. They say that sometimes cholesterol is the best indicator, sometimes HDL is indicator. So in case of lipid profile, you can say it as surrogate. Safety biomarkers. Safety biomarkers, for example, take an ECG graph. No, if there is Q wave inversion, if there is no Q wave inversion means yes, the patient is on the safe side, like that. Safety biomarkers. If the person is on the particular in these levels, yes, you can say it as a safety biomarker. Means there are various types of biomarkers. Okay, coming to cardiac diseases overview or rehospitalization of acute coronary syndrome due to the high. Why I have taken cardiac disease overview, because what is the major incidence of this cardiac disease means acute coronary syndrome and heart failure are the most important diseases among the present cardiac diseases, because so ultimately number of researchers came in the best way to diagnose, assess the risk and manage the patients. Science and symptoms. Okay, how do you classify MI directly? Because myocardial ischemia, first of all, I just want to go with how do you classify myocardial infarction? Then ultimately, how you are going to assess the various biomarkers. So, how do you classify MI? If a patient came with chest pain into the hospital or the ED or the emergency department or your OPD, so how you are going to classify as a clinician, you should know. One is signs and symptoms. Second is ECG changes. Third one is biomarkers. Fourth one is imaging, if time permits. And fifth one is any interventional things. So on these five, you are going to assess a patient whether he is having MI or not. So basing on the urgency, you will go with the steps. Suppose if the patient is having slightly okay, he is okay means, then simultaneously you will go with ECG, then simultaneously biomarkers. So basing on that, so of course, always signs and symptoms comes on the first place. So that's why presenting complaints or history of presenting complaints plays an important role always. So when is the chest pain, time, duration, etc. You know very well about the signs and symptoms of acute coronary syndrome. Rather than myocardial infarction, I'm directly saying ACS. Because acute coronary syndrome, it may lead to infarction or it may not lead to infarction. Better term it as ACS. Just I'm saying. So what are the various signs of ACS, acute coronary syndrome? It might be chest pain. It might be few radiating to the left arm, jaw, back, and to abdomen. You know very well, and it may be persisting from few seconds to minutes, or it may be intermittent, especially on exertion, etc. So it's also associated with shortness of breath and anxiety. There are a lot of other symptoms, you know very well, like additional symptoms like unusual tiredness, nausea, vomiting, sudden dizziness, heartburn like feeling, discomfort in the back, neck, shoulder, jaw, etc. So all these things may add up. The patient may or may not be able to from the attendants. Okay. We want to pull out the blood sample. One most important thing is presence of chest pain. Without that, it is not perfect. It is not perfect to assess or go for diagnosis of ACS. So chest pain is the most important thing. So as I told, first is history of presenting complaints. Next is ECG changes. Okay, ECG changes, two things. I'm not going to ECG also very depth, but I am saying what to take into consideration for ECG to diagnose for MI. One thing is that elevation of ST segment or depression of ST segment. Only two things you observe. I'm not saying it is the only perfect diagnostic point, yeah, but yes, it carries most importance. First is ST segment elevation or ST segment depression, because ST segment depression is also called as non-ST elevation MI. So you just see whether there are any ECG changes. So means slightly we may be knowing, we may be confused, maybe we may be a bit more anxious on to see ECG. At some points we may be we are not so much perfect. At some points we may be missing, but 2 or 3 points you should consider to diagnose it as an MI. So what is that? So ST segment elevation, basically on the right side I have given the J point. The J point is called as the junction point. See, this is P wave and Q wave is not yes, R, yes. It is the from J point to the start of T wave, there is a ST segment. So this ST segment, if it is elevated, this is ST segment elevation. Okay. So if here you see in the downwards, from the J point, from the S to the T, the baseline, usually ST will be on the isoelectric line always. This is one important point. Please remember ST. In which leads I will tell you later. So ST, after R wave, it comes your S wave. S to T segment, that should be in the isoelectric line. So if it is elevated or depressed, then you have to think there is some messy thing happening over there. So what is that? So ST, suppose S is slightly depressed below the J point, means after the J point, S to T, this line is depressed, then you call it as ST segment depression. Anyhow, suppose we will consider of ST elevation only. So right now discussing ST elevation. Sorry. Yeah, ST elevation. ST elevation means where you have to say, first of all, above 0.2 millivolts in men 40 years or of age or older, or 0.25 millivolts or above in men below 40 years of age. This is one of the standard definition for MI basing on ECG changes. I can say 1 or 2 small squares, 1 mm. In the side ECG graph, I have shown you 1 millivolt is 10 squares, right? 0.2 means 0.1 means 1 milli square, sorry, 1 small square, 0.2 means 2 small squares. So nearly 1 to 2 small squares, if the ST segment is elevated, that's enough. You can say that the patient is having MI, but one important thing is that if he's around 40 years or older, 0.2 millivolts can be considered, and he is below 40, suppose 30 years patient came to you, you can consider up to 0.25 millivolts, like 2 to 3 squares. And ST segment elevation, and where, and moreover, in women, 0.15 millivolts or 1 millivolt or above. Okay, slightly 0.1 to 1.15. So where you have to see in the leads, lead 2, lead 3, lead AVF. And moreover, when you are going to diagnose as MI is continuously 2 leads, continuous 2 leads. If there is ST segment elevation, yes, you say that the patient is having MI, provided the history is a positive of chest pain, in favor of chest pain. Next is, and more important conditions that I have written in the blue letters, without LVH or left ventricular or left ventricle hypertrophy or LVBB, means provided there is no other problem like left ventricular hypertrophy. Already the patient is having left bundle branch block. There is no need to consider, because you need to again test with the cardio biomarkers. Next level, what I'm trying to say is that first level is ECG. So check for the ST elevation in continuous 2 leads, like lead 2, lead 3 or AVF, that is continuous, and whether the ST segment is elevated by 2 squares or not. Yeah, I will go to the previous one. Next is ST segment depression, more than 1 to 2 millimeters below the baseline. Yes, on the left I have shown you, this is isoelectric line. The dotted line is isoelectric line. If the S to T is below the isoelectric line, 2 small squares below, okay, or it may be like this, or it may be like this also. So it may be, if it is down sloping, the first one is normal, second one is slightly curved, a bit trough-like. It is a down sloping ST curve, and the third one is horizontal, just slightly above the down sloping. In any of the leads, like one V5 to V6 or 1.5 mm in AVF for lead 3 or the AVF or V5 to V6, if you could see any depression or downsloping of ST segment after the J point, then you can consider it as even MI. Yeah, I'll go to the, yes. For this, suppose the patient is coming to you with the chest pain. So what happens? There are 2 chances. One is demand supply. Why there will be chest pain? If you are exerting more, the myocardium is unable to supply the demand to the peripheral tissues. Then you will get chest pain. Second thing, you are not doing anything, but still you are getting chest pain. You are getting chest pain means there is some block in the arteries. So the block may be partially occluding, the second picture, or fully occluding. So the first one is ST segment elevation is absent. So take it granted you are having ECG paper on you, but there is no ST segment elevation. ST segment elevation absent means think over either it should be ST depression, okay, or even T wave inversion also. Absent means I'm saying. So if there is ST segment elevation is absent, and when the biomarkers are not increased, then and if the patient is having chest pain, then it is called as unstable angina. So to diagnose unstable angina also, it is not so much easy, because the patient will be anxious, panic because of chest pain. Doctor will also be in panic what to do with the associates. But the thing is that slightly, if we go in detail, if there are no increase in biomarkers, if there is no ST segment elevation, then you can say it as unstable angina. If there is increased biomarker level, then there is a non-STMA type 2. Here, the second thing is that atherothrombotic. So partially excluding thrombus. So in the other side, the ST segment elevation is absent. Then even you can think over it as unstable angina. Suppose if the ST segment elevation is present with increased biomarker level, STEMI, then it is known as QVEMI or STEMI. So means from this diagram, I could say one thing is that when the patient is in danger, positive history of signs and symptoms of MI with ST segment elevation with increased biomarker levels. That is the most dangerous. STEMI is always dangerous. So why STEMI is how STEMI differs from non-ST elevation is that ST elevation myocardial infarction involves the entire myocardium, entire the heart muscle, whereas non-ST elevation involves only the subendocardial portion. Endocardium is the lower innermost layer. Just below that there is a slight infarction or the ischemia to infarction. Non-ST segment elevation, but still the patient presents with chest pain, then you have to go for even biomarkers also. Don't go with ECG. Means you can ask me like, sir, what is the need when there is no ST elevation in the EMI? Always rely upon the patient's clinical signs and symptoms. The patient is saying squeezing chest pain means immediately sideway you draw the blood and you send it for biomarker. Yeah. So coming to next step, ECG step is over. Next is the cardiac biomarkers. Okay, cardiac biomarkers. What is an ideal cardiac biomarker? So what is an ideal cardiac biomarker? No, sir. This is the best cardiac biomarker. On what basis are you going to judge? One is high myocardial content. Means it should be high in the myocardium. Damn sure. Okay. Now fasting blood glucose means rather than any other tissues. Okay, if you want to go for in the blood sample, it is easily accessible. Means yes, you can go like that. What is the ideal cardiac biomarker? It should be high in the myocardial content, myocardial muscle. Next is absent in the non-myocardial tissue. No, this is also present in skeletal muscle. Means it is not a true cardiac biomarker. Rapid release into blood after the attack. Immediately, as soon as the patient is having chest pain, within few hours, we want the result. That is an ideal biomarker. Next, high sensitivity and specificity. Rapid clearance from the blood and the body fluids. Means immediately it should be absorbed or metabolized. And detection by rapid, easy, and simple assays. This is very true regarding any biomarker, not only cardiac, yes. But in case of cardiac biomarker, it should be very much, what I could say is that immediately you should be able to assess. So when coming to history of biomarkers, it is considered important in olden days used in we are having various biomarkers like AST, CKMB, troponins, etc. But AST is considered to be important in olden days, but gradually AST is also elevated in liver and liver problems. So AST is ruled out. Next, slowly in 1979, WHO identified it as the ideal biomarker, that is CKMB. And it was used for nearly 2 decades. And in the late 1990s, one more serum immunoassay was developed, that is your troponin. So gradually from then onwards, various other biomarkers are being identified. Okay. So there are many cardiac biomarkers. One is obsolete, like aspartate transaminase, what I'm trying to say now. Next one is, so I have divided into three types: obsolete, established, and emerging. Means which are emerging means which are in picture right now nowadays. So obsolete, which are outdated, like aspartate aminotransferase, total CK, yes, creatine kinase, and also LDH. Established means perfect. If we are going to consider this blood test like troponin D, troponin I, and CKMB or myoglobin, this green I have kept now. These four are most important. It's damn sure it is going to say that yes, myocardial infarction is absolutely present in these people. Emerging, of course, emerging means in a novel biomarkers like HFA-BP, beta natriuretic peptide, ischemia IMA, pregnancy-associated plasma protein, copeptins, and growth differentiation factor. So I need to discuss slow. So I'm just being a bit. I'm a bit fast. Please. Okay. Types of cardiac biomarkers. Like on what basis? Like what these biomarkers are there? There are n number of biomarkers, but what it is going to depict? There is CRP and interleukin 6 and also pentraxin. What does that depict? It shows that there is some inflammatory marker. Inflammation is going on in the cardiac muscle. That is the first point. Okay. So I have divided into three categories. One is inflammation markers. Second is plaque destabilization markers. Third one is myocardial necrosis markers. Okay. So inflammation, something there is a fishy thing going on inside. There is some inflammation means you go for CRP, but you can't rely upon CRP because inflammation can happen anywhere in the body, even in autoimmune diseases. But there is no other problem, but the patient is having chest pain. Yes, of course, you can rely upon the CRP, interleukin 6 and also pentraxin. Next, plaque destabilization like myeloperoxidase, PAP. Next is soluble cluster differentiation ligand and also tumor necrosis factor. Myocardial necrosis markers. Yes, these are the biomarkers which say there is a troponin, myoglobin, CKMB, heart fatty acid binding protein, BNAT peptide, and also IMA, all those things. So we'll discuss one by one. Yes, as I told you, when to land up into markers, biomarkers, acute chest pain. So always clinical history important. So positive ECG, and of course troponin is considered as a gold standard. Myocardial necrosis with evidence of ischemia, and ultimately it leads to electrical instability, impaired contractility, cardiac inflammation, tissue necrosis, all those things. So coming to sensitivity, before going into the markers, coming to sensitivity, which marker is having more sensitivity? Sensitivity means, see, I will tell you the last one. The last one is the troponin. The last one is the sensitivity means even, for example, you should be able to know that the patient is having infarction in his body when 1 ml of some biomarker is released. It is not 1 ml, even point in fractions of biomarker or chemical is released from the myocardial muscle. It should be able to detect it in the blood. So that is what you call it as sensitivity. So here sensitivity is your troponin. Most of all is troponin. Okay, so basing on this, there's a sensitivity chart like ECG, 2D-co, creatinine kinase MB, means so CKMB, and of course troponin. And AST also, it is not, it means it comes to the first or second place, last place. And whereas troponin comes in the first place, the sensitivity. Coming to the troponins, always when you go to any hospital, suppose a patient gets admitted into the hospital with chest pain. So his relatives will bring you or WhatsApp you the reports. Sir, these are the things they are doing daily. Why we don't know? Unnecessarily they are doing. Some patients will say, and even we also think, oh, it may be, but it is not the thing. So there are some biochemical markers or biomarkers or the biological markers. There are a lot of biological markers which has to be done on particular days. Then only you will be able to say the patient's prognosis as well as diagnosis. Not rather than diagnosis, prognosis. When the patient is going to be discharged, how the patient is going to be landed into trouble, and what are the other treatments. So considering all these biomarkers, you have to assess the patient. The most important gold standard is troponin. So what is troponin? Troponin is present in the contractile apparatus within the cardiac muscles. So cardiac muscles, this troponin is present in the cardiac muscles. So it helps in what exactly helps in, right? It facilitates the interaction between actin and myosin filaments as a part of the sliding filament mechanism of the muscle contraction. The muscle has to contract. So for this, the the I band, Z band, all these things, they should come closer to each other, so that there will be absolutely what you call contraction of the muscle. So for this, for facilitation of this contraction, there should be some actin myosin interaction should be there. So for this actin and myosin interaction, myosin means this muscular fiber, the actin myosin complex. The blue one is a myosin, whereas the green one or the yellow one is an actin. You see the yellow ball-like structure is actin. Then, sir, actin is yellow color, when why the myosin is the blue color. Then how these two have joined? Yes, through the troponins. Through the troponins. These long chains, what you see are the troponins. So what is this one troponin molecule consists of? It consists of troponin C, troponin I, and troponin T. Okay, it's just like a box or a small, small apparatus like troponin C, troponin I, and troponin T. So this what it does is it tries to attach this actin with the myosin, this muscular fibers. So when actin and myosin joins, only the muscle contraction will happen. The exchange happens. So this troponin C, troponin I, and troponin T, these are three are there components. But how does it differ from the skeletal muscle? Troponin, skeletal muscle means all the other muscles of the body. Troponin C is present in all other muscles of the body, whereas troponin I and troponin T are present only in the cardiac muscle. So when you are seeing the patient's reports, trop T and trop I are the latest investigations now they are following. It's not the troponin C, because if you are having any injury, any injury to the skeletal muscle also, like any injury to the arm or leg, the troponin C may rise, but they are not going to consider this troponin C as the identifying biomarker of the heart. So troponin I and troponin T are the only markers to say that the cardiac muscle is damaged. So when muscle is damaged, so this troponin I and troponin T, the chain is released, the chain is broken up. So see, here you can see. So what is this 3CTI composed of? C. Actually, C means stands up for calcium. In the from the myoneural junction, the calcium is released. So this troponin C catches the calcium, and what happens? The calcium causes muscular contraction. So the entire length of the so-called blue color is there, the tropomyosin. The tropomyosin gets contracted. Once the calcium is absorbed, the tropomyosin gets contracted. Then ultimately, this yellow colored actin gets binded up with the myosin, this blue color. Okay, because when the troponin C absorbs the calcium, ultimately it leads into contraction of this rope-like tropomyosin. So it exposes the binding sites of the actin and myosin. So the troponin T, what does troponin T then do? It attaches the troponin complex to the actin filament, and troponin I inhibits interaction with myosin heads in the absence of calcium ions. So when the calcium ions is not there, because there is muscle is infarcted, so all these things are getting released into the body. So that's why troponin I and troponin T are are measured in the blood. So troponin C is not at all considered. Next, troponin T and I. What are these CT and I? They are isoforms of the cardiac, specific to cardiac myocytes T and I. Okay. So the detection of CTN and CTNT and CTNI are the specific biomarkers of cardiac damage. It is attached to the actin thin filaments in the cardiac sarcomere and the remaining 5 to 8%. Here, one important point is that the 90 to 95% of troponin is attached to the actin thin filaments in the cardiac sarcomere. in every myocyte, in every muscle cell, cardiac troponin is attached to the so-called chain I have shown you. It is fixed to that chain, and small amount of cardiac troponin is also in cytoplasm, which is called as. So when the muscle is disturbed, when so the cytosol pool or in the troponin I all are released. The early troponin pool. Troponin. Next is this chain also breaks out. Then again, this is what you call a structurally bound CT, cardiac troponin. So since a rope-like structure, it takes time to break up and it takes time to get into the blood. So troponin is measurable up to 10 days. Okay, am I clear? Because cardiac troponin which is in the cytosol immediately shoots up. Okay, fine, but it is immediately cleared up by kidneys. By the time the patient is telling the chest pain and everything, by the time we are realizing by one day, the troponins are not visible. So one more thing is that the troponin chain is broken up. So ultimately, you will have more and more because it is a slow process. It will persisting up to 10 days. So that's why cardiac troponins are the gold standard. So that's what I say. So cardiac troponin C appears in blood of, now I will say, sir, earlier cardiac troponin T used to be measured. Now cardiac troponin I, what is the difference? T has cardiac troponin type T is more in the cytoplasm, whereas cardiac troponin I is more in the simple form. So what happens is that cardiac troponin T, it occurs in two forms, in the cytoplasm as well as the structurally bound. Whereas cardiac troponin I, it is only in the structurally bound with the rope chain. What I have shown you with the rope chain. So what happens? Trop T, first the cell gets dissolved. Myofibril cell or the myosal fiber cell gets dissolved. So troponin T increases. Then ultimately again it decreases. Then ultimately the structure also gets damaged. So there is biphasic pattern. Troponin T, it may be biphasic pattern depending on the extent of damage. But I'm saying, whereas troponin I, it is only related to purely structural. Structural means there is lot of infarction needed to damage the structure of the muscle. So definitely, if once you have gone through troponin I test, and when this I is damaged, I is increasing in the blood, when I is released in the blood, then definitely you are going to say that there is some problem with this person, and mostly it is MI, provided chest pain and also ECG signs, and it is more accurate method. So troponin I or T means, yes, if some hospitals go for troponin T, yes, no problem, but mostly troponin I only they are going. So how much how was after I had to test means, yes, sensitivities of CT-NT and CT-N1 were 99% and 96% respectively, and specificity were 78% and 88% respectively. So if CTI is normal, CTI is negative, then you can happily say that he is not MI. So that's what specificity. Okay, just ruling out. Yeah, here you can see. I will go to this. Okay. Next, nowadays, the latest advanced biomarker is your high sensitive cardiac troponin. Again, one more, because the patient will be bringing to a lot number of reports. What is this? HSCTN. HSCTN, hypersensitive cardiac troponin. What does this mean? It is troponin at concentrations 10 to 100 fold lower than the conventional SS. Normally 1 ml is detected in the blood. Then what about this? Even 0.001 should be detected. So that's why this HSCTN has come into picture. What is the use of this HSCTN? Higher negative predictive value. What does this HSCTN? The lower levels of, so high sensitive cardiac troponin levels are very less. If it is very less, then you can say it is saying negative prediction, means there is no MI. If the higher levels of higher HSCTN, it may be CTT, I mean cardiac CT, N means cardiac troponin, it may be I or T. But if it is higher, blindly you can say the presence of MI, AMI. But one more small problem is that these elevated troponin levels are even increasing lot of other conditions. Tachyarrhythmia, hypertension, anemia, hypovolemia, aortic dissection, cardiomyopathy, exercises, cardiac procedures, cardioversion, pacing, ablation, endomyocardial biopsy. Lot of things are there. But how will you differentiate this? Sir, already the patient is in having lot of headaches, but a lot of diseases. But how can I differentiate? So, like even the patient is having some autoimmune diseases, amyloidosis. Even then also it acts on the heart. Then ultimately troponin T is released. Then how can I say? How can I diagnose? The most important thing is that, of course, it's already discussed. Yeah. So what I have to consider? Is it stable levels or acute levels? Sharply raised patient with a history of chest pain, with ST elevation MI, with the troponin levels increased, blindly say you can MI. Patient with chest pain with not ST elevation MI, but troponin levels elevated, yes, then also MI. But when the patient is admitted for nearly 10 days and all the 10 days for the same kind of same levels, then you can say that it helps in DD of the chronic heart disease. Suppose there is acute troponin level elevations, then you can say that it's an acute cardiac damage. Sudden, sharp, and fall means probably in 4 to 10 days. Then it is MI. So all the, sir, for the last many years, I'm having this troponin level. Why you are getting confused with the patient? Asks, okay. But if the patient is having acute levels, though it is chronically stable, but suddenly it is shooting up, then you have to suspect MI. Okay, anyhow, for every biomarker, we need to consider a few things. The first most important thing is that normal values, possible MI, probable MI. So what is normal value is high sensitive troponin T less than 14 ng per liter. So a result of lesser than 14 ng after 6 hours of symptoms, then rules out MI. Okay. So the patient is having slight chest pain. Okay, ECG is something confusing. Better go for troponin. I'm not advising to suggest. I'm not suggesting to go for on every patient with chest pain for troponin. Just I'm saying, when you have to suspect possible MI, 14 to 30 ng per liter, and probable MI greater than 30. This is something we have to remember. Though the normal values are given on the side of the reports, but still we have to consider possible MI, probable MI, and normal MI. And troponin I, it rises in 2 to 3 hours after the onset of chest pain, but it reaches its positive value for 3 hours. Okay. Most important is on the first day after onset, it starts in 2 to 3 hours. Slowly it increases, reaches to peak, and ultimately persists for up to 10 days. Testing. Sir, how often I have to go for testing? Because every day they are pulling out the blood. This is horrible, sir. Unnecessarily they are drawing the blood. It is not the thing. For the sake of hospital, they are doing the reports. Depending on the patient's symptoms and non-probability of STEMI. So regular ECG changes, either it may be STEMI or non-STEMI. Yes, you have to repeat the test. So if the chest pain onset is more than 3 hours, then a hour, 1 hour algorithm is suggestible, means repeat every hourly. No, if the patient after 12 hours of admission, if the troponin is not raised, then also if there is the patient is having a chest pain, please repeat the troponin after 12 hours. Okay, but always conjunction or correlation with ECG. Yeah, this is the troponin. Anything you can ask doubt in the later. Yeah, please. Next is creatine kinase MB. Always a lot of people are confusing with this creatine kinase MB and CK. Sir, CK or CKMB, CKMB. CK is earlier they told that CK is most important, but CK is outdated. As I've told in the obsolete list, CK is outdated because CK is CK exists in 3 forms: CKMM, CKMB, and CKBB. CKBB exists in brain, CKMB in heart, and CKMM in the muscle. So CKMB is the ideal biomarker over here. I'm not going to discuss other two things. So CKMB, it is present in the muscle cells. Okay, the CKMB fraction being more specific, and it is a gold standard. So when you see this graph on the side by, you can see the total biomarkers and its what you call their prominence. Sharply, the first peak is myoglobin. The second peak is total creatine kinase. Third dotted line is troponin. It is elevated. The graph on the x-axis and y-axis depicts the hours from onset of infarction, whereas upper limit of normal is means the upper limit. Okay, so here CKMB, you see the straight line hours means probably 2 to 3 days. Okay, whereas the troponin, the total CK, and LDH a bit last. Okay, it's slowly elevated and slowly decreased. But sharp, the first elevating is myoglobin. So just remember this graph. So myoglobin first, next total CK. In the total CK also CKMB, because CKMB is an isoform of creatine kinase, and moreover CKMB accounts for nearly 30 to 40% of creatine kinase. CKMB is an isoform of nearly 30% of the total CK. So how can we assess this? This CK is 4 to 6 hours after onset of infarction, rise in 4 to 6 hours after onset of infarction. It peaks in about 12 hours. For all the biomarkers, there is some specific time limit. Daily some or other test the patient should be undergone till the patient is stabilized. So first we have gone for troponin. Okay, next is rise in CKMB in 4 to 6 hours after onset, and it peaks about 12 hours. Okay, it peaks about 12 hours and returns to baseline in the 3 days. 2 to 3 days max. 1 to 2 days. The best time for detection is between 6 and 48 hours, beyond which it is cleared. Hence, in case of patients late arrival, suppose that, sir, I am having 3 days back chest pain. If the patient has come to you, don't consider CKMB, because the CKMB will come to normal picture. So always, suppose, sir, 4 days back I am having chest pain, but again today I want to assess the blood test. Today you have done CKMB. Again CKMB showing rise, means then again there is a chance of reinfarction in that patient. So you have to suspect there is 2 times myocardial infarction, the first as well as the second episode. So how to calculate? This is the relative index, CK total CKMB by total CK into 100. A relative index of nearly more than 2.5 to 3 indicates very likely heart damage, and lower index suggests skeletal muscle damage. Suppose it is very low index like 2 or 1 like that, then it indicates it's only a some skeletal muscle damage. Yeah, like troponin, it also shows some false positives. Like in any muscle injuries, cardiac injury for reason other than MI, cardioversion, defibrillation, chest traumas, cardiac and non-cardiac, and even cocaine abuse also, vasospasms, tachycardia, etc. So you have to consider always biomarkers, all biomarkers you have to consider, and moreover, for every biomarker, timing is important. What time you are doing and when you are doing. And most of our next is LDH. As I told you, it slowly rises and slowly falls off, and it is not so much important considered. But some hospitals are still doing, no problem. But we have to go through this. It is one of the important enzyme. Lactate dehydrogenase is an enzyme that produces energy. So it helps rise in response to cell damage. So normal LDH levels range from 140 to 280 units per liter, or 2.34 microcapsules per liter to 4.68. These are other unit. So high level indicates MI. So though it is non-specific for cardiac tissue. Why it is non-specific? Because it is also contained in pancreas. Hello. Yeah. So this LDH is also present in pancreas, kidneys, stomach tissue, as well as red cells. So LDH, LDH, we cannot take it as granted as it is a gold standard. But LD1, again, there are two types, LD1 and LDH2. If the LDH1 is more in the reports, then you can go for it is a setting of MI. Okay, in the setting of AMI, LD rise about 10 hours and peaks at 2 days and remains elevated for up to 8 days. Okay. AST, as I said already, it's the oldest biomarker which we are not considering nowadays, but still I have added only a few things about AST. SVOT. So its peak level is in 18 to 24 hours. It appears in 6 to 8 hours and comes to normal in 5 days. So increased AST levels occur in MI, but it is increasing 4 to 10 times the normal and peaks in 24 hours and returns to normal by 3rd to 7th day. Okay. Of course, it is increase in liver disease also, so it is not considered as a gold marker. As I told you, as shown you in the graph, another best biomarker is your myoglobin. Myoglobin is nothing but just like hemoglobin, it is an oxygen carrier. It is an oxygen carrier which is stored in the muscle, because muscle, like RBC, it is not a tiny organ, tiny structure. Muscle is a big structure, so it requires more oxygen. So myoglobin stores much oxygen. Myoglobin stores much oxygen, and when required, it releases this. So myoglobin is a heme protein, small globular oxygen carrying protein found in heart and striated skeletal muscle. The first method to detect myoglobin was developed in the 1970s, but it is released from all the damaged muscles. Why this myoglobin is shown in the first peak only means myoglobin is very lightweight. So it easily diffuses in between the skeletal muscle gap. Whenever it is whenever there is a chance, whenever there is a damage to myocardial muscle, yes, first thing is myoglobin comes out, because it is very lightweight and easily diffusible capacity. So what happens? It comes out and enters the blood. So that's why, sir, I'm having chest pain just now for the last 30 minutes or 1 hour. Okay, no problem. You can go for even myoglobin also. That is not a problem. So don't wait for troponins to get raised or CK to get raised. Of course, you have to go for ECG, which is a gold standard. So you have to go for the myoglobin. It is not utilized often for AMI or cardiac damage assessment, because every skeletal muscle every skeletal muscle has this myoglobin, and moreover, it is not indicated in the AMI. It is indicated gold standard provided only within the first few hours, and moreover, it has short half-life. It will be easily disintegrated or metabolized. So only if you sharply peaks and sharply falls. Normal values for myoglobin 17.4 to 105.7 ng per ml. It rises in first 1 to 3 hours, peak values in 6 to 9 hours, and returns to normal in 12 hours. Katam. Within the first half day, myoglobin will come to normal. So depending on the patient signs, on and onset of signs and symptoms, you have to go for the biomarker. Yes. See, the first one, the pink colored is a biomarker of, sorry, myoglobin. Next is the troponin, and a blue color is the LDH. Okay, and even AST also. So I could say myoglobin, creatine kinase, and troponin. These three you please consider for as a gold standard. LDH and AST, they are not considering, but if they do the investigations or if the patient is having reports, yes, you have to consider. Coming to next few important biomarkers, the short biomarkers. What are modified albumin, ischemia modified albumin. Normally, albumin molecules in the tissue, it will be binding up all the metals like cobalt, etc. This albumin will be able to attract the metal molecules. What happens? Ischemia modified albumin. Suppose if the muscle is necrosed, what happens? The albumin is a protein, right? The protein, each protein will have again N terminus and a C terminus like that. This N terminus means one end, one portion is damaged, so it could not identify the particular cobalt. So what happens is that I'll tell you. Okay, the value ranges from 52 to 116 kilo units per liter, whereas IM is elevated within first 6 to 10 minutes after ischemia, remains elevated for up to 6 to 12 hours, returns within to normal within the first 1 day. So immediately after ischemia, this ischemia related the chemical mediators of the inflammation or the ischemic muscle, it will damage this albumin. So how do you calculate, sir? So what is the procedure means? Yes. Now, this is a principle, a known amount of cobalt. And suppose you take a test tube, in that you take the patient serum and you add some cobalt atoms, this molecules or atoms, whatever it may be, the cobalt containing liquid. So what happens? If it is non-ischemic sample, definitely all the cobalt molecules are getting absorbed. Whereas if it is a ischemic sample, the cobalt molecules will be swimming freely as it is. So basing on how much you added, how many cobalt atoms are remaining with the help of decolorizing agent, you can easily identify whether it is an ischemic sample or non-ischemic sample. That is a ischemic modified albumin. The drawback with ischemic modified albumin is that even if the myocardial muscle is exposed to hypoxia or acidosis, there is a chance even ischemia can happen anytime, right? So there's a chance. So there's a graph. So some ischemia, some necrosis, green to red, left side green, all ischemia, right side red, all necrosis. Okay. Next is IL-6, interleukins, you know very well. Stronger relation in STEMI, ST-EMI, ST elevation EMI than non-ST elevation EMI. Stronger relation. There is a powerful predictor of recurrent events of CAD, may suggest the infarct size. So IL-6, frequently you see in many hospitals you can see these reports. IL-6, or why they are doing this? Yes, interleukin 6. Yes, it is a stronger relation in ST elevation EMI. Suppose the patient is having positive ECG finding of ST elevation, then with positive interleukins or high values of interleukins, then ultimately then it is called as supporting. There is some infarction. So when you are giving anti-IL-6 receptors, anti-IL-6 injections, normal values, so it reduces inflammation. Then it is also useful as therapeutic. Normal values lesser than or equal to 0 to 5.9 picogram per ml. So interleukin 6, in between you can do to the patient. Doctor, someone is drawing on the screen. Hello. Hello. Hello.
Yeah, doctor.
Someone is drawing on the screen.
You go ahead, doctor. We'll take it.
Please. Yeah, please. Interleukin 6. It stimulates the liver and increases the blood viscosity. Activates monocytes by deposition of fibrogen. What is the role of interleukins? Means you know all these things. These are the chemical mediators, but they increases LDL intake by the macrophages. So when the macrophages, you know very well, when you remember the endothelium of the heart blood vessel, when the macrophages and platelets are just getting aggregated, there is lot of LDL they are absorbing, and ultimately one by one macrophage is getting piled up, which is capturing this LDL. This LDL, okay. So gradually the cholesterol is getting piled up inside of the arteries. So it stimulates hepatocyte acute response, It stimulates the macrophages, increasing LDL intake. So interleukin 6, if it is more, then ultimately LDL capacity absorption, macrophages absorption of LDL increases, and ultimately it favors atherosclerosis. So it favors, I say it favors. So it indirectly says that it predicts in future the patient is going to have MI. Next, of course, this is same thing. Next, heart type fatty acid binding protein, HFA-BP. This is a very new biomarker, we can say, but nowadays they are also following this. What is this heart fatty? Normally, FABP is common. HFABP means heart type, which is depicting the heart. That is a FABP. It is a very stable, low molecular weight protein in the myocardium cells or the myocardial cytoplasm. What do? They transport the fatty acids from the cell membrane to the mitochondria. So after the myocardial damage, what happens? All the things are released. So ultimately, this myocardial, after the myocardial damage, they escape through the space, interstitial space. So heart FABP appears 1 to 3 hours after the onset of MI. Peak levels rises to 6 hours and it comes back to normal in 24 hours. It improves the diagnostic ability and additive value only. It does not say that definitely there is myocardial infarction. There is some damage, but it can't say that there is absolutely infarction, entire muscle, less muscle like that. So it says that only prognostic factor and additive value to the ECG. Yes. Most of the things, most of the people they ask, how to go for natriuretic peptide? And there is atrial natriuretic factor and also beta natriuretic peptide. Sorry, brain natriuretic peptide. So ANP and BNP are there, and even C type is also there. What are these? These are peptides, or containing of so many amino acids. Natriuresis. Natriuresis means they reduce the blood pressure by enhancing the sodium and water excretion from the body. That's all. Their job is to just release the sodium and water from the body. So natriuresis, you know very well. How does it, this sympathetic nervous system activity, vasopressin activity, means all these conditions. I'm not going because a lot of slides are there. This is also, I just want to say the same thing. Actions of natriuretic peptides, natriuresis, diuresis, improving the GFR, filtration fraction, inhibit the renin release from the renin-angiotensin mechanism, decreases the angiotensin 2, decreases circulating aldosterones. It decreases the arterial, it causes arterial hypotension, means it reduces the hypertension. So what does this do? On brain, on vascular system, on heart and kidneys. So there is increased sodium and water excretion on the kidneys. Whereas on heart, it reduces the cardiac load and hypertrophy. It prevents the hypertrophy and also fibrosis inhibition. Whereas on vascular system, it causes vasodilation and also angiogenic effects. Whereas on nervous system, it causes sympathetic nervous system inhibition and vasovagal syncope. If it is a vasovagal syncope, yes, it's natriuretic peptides. So what is normal values of BNP? Brain natriuretic peptide usually means I am saying as an UG student or some student, I can say that. So we are getting confused why brain natriuretic peptide came over here because it is identified in the porcerian brain earlier. And moreover, when compared to ANP, BNP is more present in the left ventricle, in the atrium. So that's why, in the ventricle, left ventricle, when compared to ANP. So BNP is the only best predictor. So when it is present more in the left ventricle, so when BNP values are more, it depicts the left ventricle functioning. Left ventricle functioning. Of course, ejection fraction is by the left ventricle only. So it is the best left ventricular ejection fraction predictor. If it is above 100 mg, 100 pg per ml, BNP is abnormal. Lesser than 100 pg is normal, whereas greater than 500 is abnormal. Means absolutely abnormal, like heart failure. And even this BNP also depends on the age group. Lesser than 50 years age group, 125, okay, can be considered. And greater than 50 years, up to 900. See, age group, suppose 50 years age group lady came to you. What is normal? No, 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 100 is normal. So 101, my teacher told it's 100. Don't, it's not 101 means it is not higher. Up to 125 you can consider. But in 50 years, lesser than 50 years, how when you are going to consider it as heart failure when it is greater than 450 picogram. Okay. Suppose if the patient is above 50 years, 900, greater than 900 picogram per ml indicates a heart failure. Okay, so up to 900. Okay, give some relaxation to the old age people or them. So above 50 years, yeah, please. Just try to consider, just think over, correlate clinically with all the other biomarkers, then only you come to one this thing, confirmation. It has 85% positive predictive value and 95% negative predictive value. Always every biomarker is based on positive predictive value or negative predictive value. Negative predictive value, 95% it is having, means if it is normal, you can relax. It says that there is no problem with the left ventricle. Next is CRP. Sir, CRP is a routine blood test. Do I need to consider? Means yes, CRP is considered. When all are coming into stable, all reports are coming into stable. Fourth day is not for time pass. We are going to give blood test. Okay, today we'll write some blood test like CRP. It's not that. CRP also has some good importance. CRP is synthesized by the liver, stimulated by the cytokines. Cytokines means all the inflammatory mediators, like cytokines and interleukins. So CRP levels differ by sex and increase in the acute illness. CRP, we say that 0.1 to 3. Sorry, 1 to 3 is normal. 0.1 to 3 is okay, somewhat better. Okay, 1 to 3 is moderate risk. Greater than 3 is increased risk, whereas lesser than 1 is shows low risk. But CRP greater than 10 indicate an acute illness. That you remember. Even it's a baby or if it's an adult, if CRP is more than 10, please see that there is some acute fishy thing going on over there. Okay. CRP, what does it do? What is its role? It helps the endothelium nitric oxide release, cytokine production, but it is non-specific to MI. That is most important because CRP, if the patient is having rheumatoid arthritis, the CRP will be around 30, 40, we can't say. But sudden, last week report it was 30, sir. Now today suddenly it was 50 with chest pain means yes, we have to consider. So 90th centile is 3.3 mg per liter, whereas 99th centile is 10. So maximum you can consider up to 10. Beyond 10, you can't take risk. And acute phase stimulus, it can go up to 500 also. So CRP, it is supportive to the mind. And of course, everyone says that LDL, HDL, these are the, as I have told, some biomarkers are predictive. And then you can predict the patient. No. In future, you are going to have one episode of heart attack. Better reduce your cholesterol. Nowadays, every person is bringing the reports. So this cholesterol is also one of the important report or the biomarker for us to consider. It's not that after getting admitted, sorry, fine. And whereas triglycerides below 150 is suggestible. So just you remember this blue lines. Homocysteine. What is this homocysteine? Nowadays we are going to listen. We are going to hear nowadays. I will tell you a small example. Take a few minutes. A patient got admitted for typhoid fever in a hospital. Later, after IV injections, he got a big, not big, he got a thrombus in the axillary vein. So the patient's attendant, the doctors, consulting doctors told her that the patient is having thrombus in the axillary vein and he's having severe pain. So they consider it as side effect of IV cannula, and they have seen by Doppler angiography venography. So ultimately, there is some clot in the axillary vein exactly at the junction. It is causing severe pain. So the doctors are diagnosing it as doubtful whether it may be due to secondary infection after the IV cannula, something happened, or any other problem. Then after typhoid fever, he got checked with this homocysteine levels. This homocysteine levels are abnormally increased. Then homocysteine levels, what does this do? It favors thrombosis. It favors intimal thickening. It favors thrombosis. That is most important. Funny thing is that whether it may be due to some hyperins or other thing, I don't know. Then I told I have given Baptisha and even I have given Arnica also. I have given these two medicines. Uh, when he has stopped this, what you call intravenous heparins and also some tablet for 3 months, this doctor suggested. After 2 months or 1.5 months, also there is no change in the axillary vein. But after giving Arnica and Baptisha, his levels are very much homocysteine levels. How it see? I am not saying directly it is related, yet to be understood. Just a beginner whether it's correct, but I have correlated in that way. But doctor suggested 1 month of normalcy. So much. It is a risk factor for the development of atherosclerosis. This homocysteine came means methionine. Methionine amino acid, when you take it from the diet, it is converted to homocysteine. So when this homocysteine is increased, it is increased in the vascular injury. So what does this do? This nitric oxide is synthesized in the endothelium layers. So what does this homocysteine do? This homocysteine interferes with the nitric oxide. What does this nitric oxide do? Actually, it helps the endothelium and also helps in the vascular dilator tone, regulation of local cell growth, and protection of the vessel wall. The heart blood vessel wall is there. It will protect nitric oxide. This homocysteine avoids. Homocysteine competes with the nitric oxide and ultimately it damages the endothelium. Research says that homocysteine levels are good predictors than cholesterol levels in assessing heart disease. Okay, so elevated homocysteine. And how can you say that homocysteine? Sorry, how can what you can advise for the people with hyperhomocysteinemia means? Yes, you can say that you take enormous amount of B complex because uh, B complex vitamin enhances the homocysteine metabolism. So see here you on the right side you can see venous thrombosis or venous thromboembolism in the arteries, primary arterial thrombosis. And myocardium, yes, it damages the myocardial infarction causes and also stroke. Homocysteine levels for every marker, there is a normal level like less than 6.3. Greater is 6.3. Means okay, moderate is 10. More risk 15 and 20. There's more and more risk in the milli micromole per liter homocysteine. Soluble CD40 ligand. What is this? It is also a protein. It suggests there is inflammation and platelet interaction with the plaque and is found increase in acute coronary syndrome. So that reflects both inflammation and platelet interaction with the plaque. So if there is a atherosclerotic plaque and it is found increase in ACS, soluble CD40 ligand. Just remember this. This markers of platelet activation that can be used to identify the disease activity even before myocardial necrosis occurs. So before there is a myocardial necrosis, there is a it suggests yes he is going to have MI. So it's a predictive value. Predictive provides therapeutic planning. It's a predictive biomarker. So it is pro-inflammatory for endothelial cells and promotes coagulation. Since it promotes coagulation, it is a bad biomarker. So on and off, if the patient is having a history of MI, So you can go for entire health checkup means, yes, you can even add this soluble CD40 ligand used in prognostication rather than diagnosis. Normal values are 0.8 to 2.1. Coming to LAPA, or the lipoprotein associated phospholipase, I mean LP, PLA2. Okay, it is a platelet activating factor. So platelets, when they are aggregated or when they are activated, you know very well, they segregate the lipid fragments. So it activates the platelets, stimulates the platelets, causes more damage to the endothelium. So it is mostly used as a research tool and in risk assessment. So the normal values are lesser than 200 ng per ml. Myeloperoxidase, it is an enzyme stored in the granules of polymorphonuclear cells. The WBCs are polymorphonuclear cells, the granulocytes. This myeloperoxidase is an enzyme. It is stored in that granules. So it is released into the extracellular. There is inflammation in the blood. So it is elevated in the blood vessels where a plaque is present and found to be increased in coronary artery disease and acute coronary syndrome. So it depicts the prognostic factors. Who arrive with chest pain? Sir, I'm having recurrent chest pain. Okay, go for even myeloperoxidase also. There is a chance. Where there is a problem, we can't say. So the elevated levels, more than 350 microgram per liter, experience a marked increased cardiac risk. Okay. So MPO serves as both a biomarker as well as mediator of vascular inflammation. Next, PAPA, the pregnancy-associated plasma protein. So it is insulin growth factor. It is a metalloproteinase. Elevated levels means, suppose if it is increased, what does it do? It is an indication of there is neovascularization in the coronary artery. Means there are new blood vessels. Means collateral circulation is going to form because there is some block, incipient plaque rupture is going to happen. So there is a chance of collateral circulation. Yes. So more than or equal to 0.5 is considered normal, while level less than 0.5 MOM are considered as marked as low. So it's an indicator of adverse cardiovascular events and not used routinely. So you can't write this frequently because it is only a prognostic and not frequent. Next is choline. So see this choline on cleavage. It indicates, it released from phospholipids and suggested to indicate necrosis and ischemia. So it reduces the risk of ischemic stroke. It is useful for early risk stratification in patients, particularly if troponin results are negative on admission. Wow, that's nice. Till now we have seen only troponin negative, troponin positive. But if troponin results are negative on admission, what do you do? So it is early risk assessment in patients. Choline in healthy adults ranges from 7 to 20 micromole per liter, whereas one study, research study, the range is from 7 to 9.3. Yes, it is under still validation, and it has better value in prognostication. Okay, these are the various biomarkers I would like to say. Yeah, next is a few other biomarkers, other like soluble suppression of tumorigenicity. It also depends to the interleukin family. So what does it do? This soluble suppression of tumorigenicity factor by stretch of a cardiomyocyte when the heart is damaged. So when there is pulling up of blood from the left atrium to the left ventricle, what happens? The left ventricle is unable to pump the blood. When the left ventricle is unable to pump the blood, what happens? The left ventricle gets stretched. So when there is stretched, due to the neurohormonal receptors or the neurohormones, the signals go on, and ultimately this soluble suppression of tumorigenicity factor, or it is means it's a number of IL-1 family gets increased. So which directly or indirectly suggests the stretch of the cardiomyocyte is something happening. There is some cardiac fibroblast. There is remodeling of the cardiomyocytes. Please take care. Means there is some damage happened already. So increasing concentrations greater than 35 are indicative of adverse clinical outcome in heart failure. Okay. When combined with troponins, and also prone what you call brain natriuretic and patients with acute heart failure, SST2, adds to the risk of death. It is also predictor as well as concentration is also active biomarker. Next is galectin 3. So it belongs to the protein lectin family proteins. So where from this is coming is it is implicated, means its role is seen in fibrogenesis, myofibroblast proliferation, and ventricular remodeling. So ultimately, what does it do? When you are seeing galectin levels 3 or more, galectin 3 levels are more, it suggests there is some initial MI, and ultimately there is some remodeling happening in the left ventricle, and it is used to predict the left ventricular ejection fraction and even infarction size also. It is a funny, not funny thing. Yes, there are many researchers are there where troponin levels correlate with the left ventricular ejection. Troponin levels correlate with the infarction size after 4 months and when measured immediately after MI. Okay, and even this is galectin 3 is also used to predict left ventricular ejection fraction, like your BNP, brain natriuretic peptide. It also helps in the LVEF, left ventricular ejection fraction. Though it is elevated in the acute or chronic heart failure, in renal decompensation, it was a prognostic factor. Means, suppose if it is severely increased, kidneys will come into role and it will clear it up. So we can't rely upon this for sure. Yeah, it's an independent predictor of mortality and heart failure post myocardial infarction. So galectin 3 is increased means already the patient is having MI. Again, there is remodeling has happened. Again, there is a chance of MI, and surely he is approaching to death. MicroRNAs. This MicroRNAs are what are these MicroRNAs means? Suppose all RNAs should have some function like to code the proteins, but some RNA fragments that does not have any function. What we say is that wasteless, not wasteless. They are miscellaneous. They are called as non-coding RNAs. Means non-coding RNAs means microRNAs. So what do? They will not sit idle. So they will they will attach the untranslated regions of the messenger RNAs. So they are very stable. So there are many microRNAs all over the body, but microRNAs are special to the myocardial muscle. Okay, this myocardial muscle, these microRNAs are MIR 15534A, like that. They remark the dysfunction of the MI, dysfunction of the heart. So improves heart function, suppresses apoptosis, reduces infarct size, and it increases the cardiac programmed cell death. Reduces. Next, mid-region proadrenomedulin. This is one of the function. Proadrenomedulin. Pro means just before the adrenomedulla, the releasing of the hormones, just before that. So in between the formation or release of that hormone, this was released. When this is released, there is some, what does it indicate? Not only hormone is released, before that only it is released in the premature form, there is some impending danger. So what does it do? It is a precursor of adrenomedulin. It is a vasodilator from the adrenal medulla. It is elevated in the both acute and chronic heart failures and is useful in prediction of hospitalization. The plasma levels range from 0.09 to 6.6 nanomole per liter with a median of 0.73 nanomole per liter. Sorry. So AMI range from 0.09 to 6.66 nanomole per liter, and the normal range is somewhere around the 0.33 nanomole per liter. Okay, average. So, and if the microRNAs are also done, then you can say that there's a chronic heart failure because microRNAs, mid-region proadrenomedulins. So there was a research study which was conducted in the American Journal of American Cardiology. It was published. So it's a powerful predictor of adverse outcome. So it may say that there is a predictive cardiac means the person is landing into a cardiac death, especially in those with elevated means if it is combined with brain natriuretic peptide levels are also increased. Both we can combine and we can say that yes, the patient is landing into a worse prognosis. So it is a marker of prognosis. Next is copeptin. What is this copeptin? This is a copeptin is a stable terminal copeptide fragment of arginine vasopressin and regulates the free water clearance and plasma osmolality by regulating absorption of water from the kidneys. So this elevated copeptin levels are strongly predicts the mortality of a patient. It is not usually done, but because it is still under validation, it is still under consideration. It is not yet finalized. Copeptin. And the normal values are 1 to 12 picomole per liter. Copeptin is more sensitive than CTNT and myoglobin. Within the first 3 hours, like myoglobin, within the first 3 hours of AMI detection, the sensitivity of copeptin is 75.2. High copeptin concentration reflects rise of AVP in the blood, therefore predicts poor prognosis. Yes. So coming to conclusion, what I want to say, there are exhaustive biomarkers, which I want to say, but this so many biomarkers when to test what, because acute coronary syndrome or heart attack is the most important disease which is very much fatal within the so-called golden hour period. The first 6 hours is called as golden hour period, or even first 2 hours, or even first 1 hour also, depending on the attack. I'm saying, so we have to consider, we have to be quick in prescription, with quick in writing the investigations, quick to assess the diagnosis. So first most gold standard is ECG always, and more above that, patient signs and symptoms. Chest pain, without chest pain you cannot. First is chest pain, second is ECG, third one is biomarkers. Okay, fourth one, of course, you can go for further investigations like radiology, like MRI, X-ray, means many other radiology investigations, and also echocardiograph, and also percutaneous trans interventions, and also ultimately some interventional procedures are also there, invasive procedures are also there. You can go with it, but I can say, if you are whole and soul depending on biomarkers, you may wait failure. If you are depending on ECG, you may wait failure. If you are depending on chest and signs and symptoms, it may be even gastric pain also, you may be failure. So multi-marker approach, no single marker for ACS is there, but but ECG with chest pain and also with biomarkers. These three are most important. Moreover, in biomarkers, at the conclusion, I want to say, always check for the cardiac troponin T and cardiac troponin I levels with the clinical signs of acute coronary syndrome. Okay, and at the same time, high sensitive CRP, CTN, and also what you call NT, natriuretic peptides, pro BNP. Okay, and this helps us in the assessment of the risk factors with the symptoms suffering of the patient. Okay, thank you. I hope